Good afternoon, my dear friend. Today will be last lecture of autumn term of Propedeutics of Internal Medicines, and will stop on the diagnosis of the patient with acquired heart defect. First of all, I want to remember you, acquired heart defect may be formed after attacks of rheumatism, and more often cause of acquired heart deformation, acquired heart defect is rheumatic endocarditis. It may be result of sepsis, atherosclerosis, which is more characteristic for aortic heart defect. We must remember about specific venerological disease, syphilis, which also can be provoke fractures, formation of aortic heart defects, and first of all aortic regurgitation. And we must remember about injuries, which are also due to traumatic affection of the heart, may be abnormal growth of connective tissue. Now I want to stop more time on rheumatism because I said you it is more often cause formation of heart defect. Because rheumatism appears due to bacterial invasion of organism with beta-hemolytic Streptococcus group A, which is trophic to connective tissue. As a result, after some weeks, streptococcal infection, which primary may be manifested with inflammation of tonsil, pharynx, in younger period may be scarlet fever, and patient will be treated from this infectious process. Besides that, he is healthy, but you see, after sometimes 1-2 weeks, patient again feels subfebrile temperature, weakness, hydrosis, and if he go to the doctor, he can reveal problem with heart because antigen antibodies complex is trophic to connective tissue which adhere on it, and as a result will be formed pathological growth of connective tissue. Later, patient feels problems which indicate about affection of heart. It is palpitation, sometimes inflammations. Patient feels discomfort or pain in the heart region, and dyspnea because disordered heart contraction. We are talking about rheumatic myocarditis. It's more easy because rheumatic myocarditis can be completely treated without any complication. More grave if the pathological process, adhesion of outer antigen complex, will be on endocardium. As a result will be inflammation and then deformation of the valves and orifices. Rare case. Disease is manifested more actively with very high fever. As a result will be significant fatigue, general weakness, asthenia, and perspiration. But in all cases, obligatory is accompanied with problem of heart contraction, heart pain, palpitation, intermissions. As a result, due to endocarditis, will be deformation of heart structures, and first of all, process localizes near the heart orifice or heart valves. If the problem involves valves, we are talking about formation, valvular incompetence or regurgitation. If the process localizes near the orifice, we are talking about the stenosis. As a result, after attacks of rheumatism due to rheumatic endocarditis, we can meet patients with acquired heart defect, mitral stenosis or mitral regurgitation, aortic stenosis or aortic regurgitation. Same problem with right heart tricuspid stenosis or regurgitation, pulmonary trunk stenosis or regurgitation. Rheumatism involved other tissue which we reach with connective tissue in pathological process, but more significant process localizes into the heart. To talk about heart defect, I'll again remember you. Process which appears with hemodynamic during systolic and diastolic period, because if you completely understand this process, you can easily explain what will you hear during auscultation of the patient with heart defect. Systolic period manifested with active contraction of ventricle and ejection of blood in greater or lesser circulation. As a result, mitral and tricuspid valve must be closed to prevent pathological regurgitation. Blood go only into the vessels. Its orifice must be normal. Diastolic period. Heart relaxed. During this period, ventricle will be filled with blood. To come back, to prevent comeback blood flow from the greater or lesser circulation, during diastolic period, semilunar valve immediately closed, but atrioventricular valve must be opened and orifice must be definite size. Systolic period, opened semilunar valve, aortic and pulmonary trunk. Diastolic period, atrioventricular valve, mitral and tricuspid open. Now let's stop on characteristic of every heart defect, because every heart defect will be separately given on exam. Mitral stenosis or narrowing of left atrioventricular orifice. You can compare normal right atrioventricular orifice and diminish left atrioventricular orifice. And you understand that more significantly narrowed orifice avoid due to pathological growth of connective tissue after rheumatic endocarditis, and then more narrowing orifice, then more difficult blood flow. Normal mitral orifice has diameter nearly 4 to 6 cm in second degree. In pathology, its size significantly narrows it, and if it becomes less than 1.5, you see a significantly restricted blood flow into the left ventricle, and after diastolic pause, left ventricle will be empty. Left ventricle will be empty. Let's see how will be changed hemodynamic. If the mitral orifice narrowed, blood cannot go as needed into the left ventricle. To intensify this process, left atrium will be hypertrophied because it's overloaded to pressure and push blood into the left ventricle at the beginning of systolic period. But left atrium primary is weak heart chamber. When the pressure into the left atrium increases, to hold it from overloading will be involved Kitaev reflex, which is characterized with narrowing of the vessels pulmonary circulation to restrict blood flow to the left atrium, which is positive sides of Kitaev reflex, but Its negative side, due to narrowing of the pulmonary vessels, will be increased pressure in left circulation, will be increased pressure in right ventricle overloaded. To decide this problem, right ventricle also hypertrophied. To compensate diminished blood flow through the narrowed stenosis mitral orifice, primary increased pressure in left atrium and its hypertrophy. To hold it, organism involved Kitaev reflex characterized with spasm of pulmonary vessels, which overload right ventricle and provoke its hypertrophy. As a result, first of all, will be problem with left articulation due to involvement left atrium, and then problem with great articulation due to involvement right ventricle. And patient come to you with signs congestion of blood in left and greater circulation, other word with heart failure, because any hypertrophy finish with dystrophy. Before patient can weak and decide that subjectively he is healthy. Complaints of the patient with mitral stenosis characterized with congestion of blood in left articulation. If you remember last lecture when we said about diagnosis of heart failure, patient complains of dyspnea, palpitation, then cough and hemoptysis, which indicates more progressive congestion of blood in left articulation because problem with left atrium. Later, due to involvement of right ventricle and its affection, blood congested in greater circulation. Patient complains of edema on the lower extremities, and then discomfort and pain in right hypochondrium. On inspection, we can see specific acrocyanosis, which is bluish color of peripheral parts due to congestion of blood in greater circulation, and specific cyanotic bluish on the face. Facies mitralis, bluish red coloration of the chest, which is visited cut of the mitral heart defect, which are named as red heart defect. We can see dilation of jugular vein due to congestion of blood in greater circulation. You can see edema on the leg also due to congestion of blood in greater circulation. You see dilated jugular vein, you see edema on the leg. There are visible signs of the mitral heart defect and facies mitralis. Examination of the heart region. We remember process from left atrium go to right ventricle, which dilated, which hypertrophied. As a result, we can see visible pulsation search forth interspace to the left of sternum, cardiac beat, and pulsation of epigastrium region. There are visible signs hypertrophied right ventricle. On palpation, over the heart apex, we reveal specific diastolic vibration or diastolic Gadspo symptom, because blood which pushes through the narrowed orifice due to active contraction of left atrium push on the left ventricle and provoke its vibration. This process appears during diastolic period. We are talking about diastolic Gatspo symptom. Will be revealed specific characteristic of arterial pulse. First of all, will reveal asymmetric pulsation of radial artery. Pulsus difference, if you remember, we'll start examination of the pulse from both hand palpation. Pulsus different. Why? Because hypertrophied left atrium compress left subclavian artery and blood flow through the left subclavian artery becomes restricted. As a result, left radial artery will be palpated badly than right. Pulsus difference. Then we can reveal that the volume of pulse will be small. It's correlated with heart stroke. Then more empty left ventricle, then less blood in peripheral circulation. Pulsus parvus. And at last, will be revealed specific arrhythmia, which is characteristic for mitral stenosis, atrial fibrillation. If you remember, when we studied heart arrhythmia on ACG classes, I said you atrial fibrillation appeared due to 3 diseases which finish on osis: mitral stenosis, cardiosclerosis, and thyrotoxicosis. Today, we are talking about patients with mitral stenosis. Percussion of the heart will reveal displacement of the heart bodies due to hypertrophied heart chamber. Heart bodies will display upward and to the right due to hypertrophied left atrium and right ventricle. On auscultation, main picture will be over heart apex. And when we'll auscultate the heart, we'll every time come back to heart defect, because in heart defect will be change intensity of the heart sound, which is provoke fractures, formation of heart murmurs and other phenomena. First of all, we'll put stethoscope over heart apex and we'll hear the intensity of the first sound more than 2 times louder comparing with second one. Loud snapping first sound at the heart apex because decreased filling of the left ventricle during diastolic period and intensified its muscular component. Then we can hear additional third stroke during diastolic period or sound opening mitral valve, because due to increased pressure in left atrium and increased density of the valve due to growth of connective tissue, mitral valve opened with audible sound. We are talking about specific triple rhythm, which is characterized with loud first sound and additional stroke due to audible opening mitral valve. And main signs of heart defect: presystolic, diastolic murmur. When the valve opened, blood go through the narrowing orifice. If orifice narrowed, blood go with turbulence movement, which is heard as murmur. It's intensified at the end of diastole, because during this period will be active contraction of left atrium to push all blood which cannot go into the left ventricle in time through the narrowing orifice. We are talking about presystolic, crescendo, diastolic murmur. And due to Kitaev reflex and increased pressure in left circulation, we can hear X and second sound over pulmonary trunk. But I'll pay your attention and we said about specific arrhythmia, atrial fibrillation. You see, as reach mitral stenosis with auscultative signs. On exam will be separate question. Auscultate the patient with mitral stenosis. You must put stethoscope over heart apex and name all these problems. Increase for sound, triple rhythm, persystolic, diastolic moment. Not forget please about it because there are main signs of heart defect. No moment, no heart defect. And maybe atrial fibrillation. Then we can put stethoscope over heartbeat, compare second sound over aorta and pulmonary trunk to reveal X and second sound over pulmonary trunk. To clear our primary conclusion after physical examination, we'll obligatory send the patient on ECG examination because it is main method for heart diagnosis, and you reveal signs hypertrophy of heart chamber, P mitrale, widening high P wave in first standard lead, hypertrophy left atrium, and deviation electrical axis to the right, deepest wave in first standard lead because hypertrophy of right ventricle. On echocardiography, we can reveal specific heart defect. You see, as diminish left atrioventricular orifice, each is diastolic period, right atrioventricular orifice open because not affected, and how significantly diminish mitral orifice due to pathological growth of connective tissue. You see as dilated and hypertrophied left atrium comparing with normal right atrium. Also, you can assess diameter of mitral orifice. Doppler echocardiography show blood flow. Each is normal. You see normal peak of blood flow and you see passage of blood with turbulence movement. Each is characteristic for mitral stenosis. Diastolic murmur which appears before active heart contraction, before QRS complex. Я сейчас не могу говорить, у меня лекция. После полвторого. Угу. X-ray examination will reveal specific configuration of the heart. We are talking about mitral configuration. You see, due to hypertrophy of left atrium and right ventricle, heart has specific ball-like configuration. It is mitral configuration, which is characteristic for mitral stenosis. Mitral incompetence, or you can say about insufficiency of mitral valve or mitral regurgitation. You can meet any name of this heart defect because if we pay attention on pathomorphology, we are talking about insufficiency of mitral valve, which cannot close mitral orifice because shortened due to abnormal growth of connective tissue. If you pay attention on pathogenesis, hemodynamic, we can say about mitral regurgitation because main action of mitral valve close mitral orifice during systolic period to prevent comeback blood flow. After attacks of rheumatism or any other provoked fractures, mitral valve shortening and its size not correlated with diameter mitral orifice, which cannot be closed completely. As a result, during systolic period, together with normal ejection of blood into the aorta through the unclosed mitral valve, it comes back in the left atrium with turbulence movements. We are talking about formation, mitral regurgitation. You see, normally blood must go only into the aorta. In pathology, it goes two directions, into the aorta and come back in left atrium. Right ventricle health, you see, only normal blood flow into the pulmonary tract. Let's see how will be changed hemodynamic in this heart defect. Due to abnormal regurgitation, left atrium will be overfilled with blood because it takes blood from left circulation and come back blood from left ventricle. All this blood obligatory during diastolic period go into the left ventricle. Left ventricle will be overfilled with blood. We are talking about diastolic overloading left ventricle. To take all its blood, left ventricle dilated to inject hypertrophy, which is compensatory response on diastolic overloading. Compensatory hypertrophy of the left ventricle. And this process may be hold long time because left ventricle primary more active chamber of the heart. But you remember, after some time, any hypertrophic tissue dystrophy, and when the contractive response of left ventricle diminish and delayed blood volume after contraction increase, blood will be delayed into the left atrium. Overloading of left atrium accompanied with its hypertrophy and increased pressure to push blood into the left ventricle. When pressure in left atrium increases, we remember about protective compensatory Kitaev reflex, which characterized with constriction of the pulmonary vessels to hold left atrium, but it's overload right ventricle where pressure increased and compensated with hypertrophy right ventricle. In mitral regurgitation, you see all chambers of the heart involved in pathological process, but process starts from left ventricle. And complaints of the patient will be again when the heart activity will be decreased. Process compensation go to decompensation and manifested with symptoms of heart failure. And first of all, patient come to you with congestion of blood in left circulation. We remember it's manifested with dyspnea, palpitation, cough, and hemoptysis. On inspection, due to more problem with left circulation will be central cyanosis. On inspection will be bluish color of whole trunk, central cyanosis. On palpation will reveal problem with left ventricle. Due to its hypertrophy, apex beat will be displaced. It becomes diffuse, high, and resistance. On palpation, will reveal problem with heart apex, which display becomes diffuse, high, and resistant. Да. Привет, у меня лекция, я до 1:30. Да. Percussion of the heart reveal displacement all heart bodies about which we said with you. First of all and more significantly will be displacement left heart body due to hypertrophy left ventricle, then upper and right. But more significantly will be hypertrophy left ventricle. On auscultation will again reveal more problem over heart apex because mitral heart defect. And on contrary from mitral stenosis, First sound over heart apex will be decreased because no valvular component which cannot be closed and decreased macular component due to hypertrophied left ventricle. Both components of the first sound decreased. And main signs of heart defect: systolic murmur over the heart apex due to regurgitation, which irradiates in 0 point, which is mid-axillary line along fifth index pave. If you remember, for organic heart murmur is characteristic irradiation except mitral stenosis. All other heart defects, murmur will have irradiated point. For mitral regurgitation, which is 0 point. And over heart base will have excellent second sound over the pulmonary trunk due to increased pressure in left circulation. But again, pay your attention. Visited cut of the mitral regurgitation is systolic murmur at the heart apex with irradiation to the 0 point. Because we remember, no murmur, no heart defect. On ECG, will reveal signs hypertrophy, atrium and ventricle. Hypertrophy of left ventricle manifested with P mitrale, widened high P wave in first standardly, and more intensively hypertrophied left ventricle. As a result, electrical axis deviate to the left. We reveal deep S wave in third standard lead. On X-ray examination, due to hypertrophy all heart chambers, heart again resembles ball-like configuration, mitral configuration, which is characteristic for both mitral heart defect. Echocardiography will show you abnormal blood flow from left ventricle into the left atrium. You see abnormal blood flow, which is shown with red color. Normal blood flow into the aorta with bluish color. Doppler echocardiography also will show abnormal regurgitated blood flow, which is characterized with lower peak during diastolic period. Aortic heart defects. We'll stop on two aortic heart defects, aortic stenosis and aortic regurgitation. Aortic stenosis. You see, narrow with aortic orifice due to abnormal growth of connective tissue compared with normal pulmonary trunk orifice. As a result, it restricts blood flow during systolic period, which cannot be adequately ejected in greater circulation. You can compare normal and restricted blood flow. Let's see how will we change hemodynamic. Due to narrow with aortic orifice, to compensate heart stroke, left ventricle must be more intensively contracted, which is possible due to increased pressure and hypertrophy left ventricle. In this case, will be compensatory hypertrophied left ventricle. And you understand then more significantly diminished aortic orifice that less blood go in the systemic circulation. Will be hypoxia, and first of all problem will be with brain then with heart because next organ which needed more intensive blood flow, and then with other organs. Later will be signs hypertrophy decompensation. Complaints of the patient. First of all, connected with insufficient blood injection into the arterial system and decreased blood supply of inner organ. Patient feels heart pain which intensified after physical exercise because they needed more intensive heart contraction and it becomes impossible. Pain resembles attacks of angina pectoris, but angina pectoris is caused due to atherosclerosis. This pain is caused due to primary narrowing of aortic orifice. Blood supply non-adequate. We remember about compensatory hypertrophy. Myocardium, which needed more intensive blood flow because mass of the muscles increased. Problem with central nervous system. I said you, brain very sensitive to low blood flow. Patient feels giddiness, headache, feels tendency to fainting due to disordered blood supply to the brain. And later will be signs decompensated activity of left ventricle, which manifested with congestion of blood and less articulation. Patient feels dyspnea, palpitation, cough, and hemoptysis. I'll pay your attention if you was attentive. When we said about mitral heart defect, complaints of patient will be connected only with decompensation of the heart, otherwise with heart failure. Aortic heart defect, first problem will be with blood supply in arterial system. A later problem with heart. Inspection. On contrary from mitral heart defect, which was named as red heart defect, patients with aortic heart defect are pale because insufficiency of the blood in arterial system. Pale heart defect, and sometimes doctor can send our patient on the blood analysis to reveal anemia, but no problems with red blood cells, problem with blood flow. On palpation, will reveal problem with apex beat, which will be displaced, becomes diffuse, high and resistance because hypertrophy left ventricle, and specific Getspor symptom which may be revealed over heartbeat. We put our palm over aorta and feel specific systolic vibration. Getspor symptom may be revealed both heart defect due to narrowing of the heart orifice, mitral stenosis over heart apex diastolic Getspor, aortic stenosis over aorta, systolic Getspor symptom. And we can reveal specific characteristic of arterial pulse. On palpation of radial artery, will reveal that pulse will be small, sometimes may be rare because difficult contraction of the left ventricle. On percussion, will reveal problem only with one heart chamber. Heart body displaced to the left due to hypertrophied left ventricle. On auscultation, all more problem will be over aorta, but we remember order of heart auscultation, and first of all we'll start from heart apex, where will be revealed diminished first sound due to hypertrophied left ventricle and decreased muscular component. Second sound over aorta also will be diminished due to decreased heart stroke and blood pressure. And we can hear loud, rough systolic movement over aorta irradiated onto the carotid arteries. Turbulence movement through the narrowed aortic orifice. Turbulence blood movement through the narrowed aortic orifice. Systolic movement. And systolic blood pressure decreased because decreased heart stroke. A systolic pressure depends from heart stroke. Diastolic pressure will be nearest no. As a result, will be decreased pulse pressure. You remember, pulse pressure needed to normal filtration of urine. Due to decreased pulse pressure will be slightly decreased process filtration of urine and removing from our organism toxic substances, which explain bad condition of the patient. And again, I'll pay your attention. Visited cutoff aortic stenosis is systolic movement over aorta. Each is main. You see order auscultation of carotid artery. This question will be given separately on exam. First of all, you palpate carotid artery and then carefully put stethoscope. Position carotid artery under mandibular medially from sternocleidomastoideus muscle. On ECG, will reveal signs hypertrophied left ventricle, deep S wave in third standard lead and high R wave in fifth, sixth chest lead. On X-ray examination will be specific aortic heart configuration which resembles shoes, mitral heart resembles ball, aortic heart resembles shoes due to significant hypertrophy of the left ventricle. And may be revealed slight dilation of ascending aorta due to its post-stenotic dilation. When during compensatory period, hypertrophied left ventricle intensively eject blood, it push on the ascending part of aorta and it may be dilated. Echocardiography reveal narrowed aortic orifice. You see as significantly it's narrowed and as significantly will be restricted blood flow into the aorta. Doppler echocardiography show pathological peaks of turbulence blood flow through the narrowed orifice into the aorta. And last heart defect on which we'll stop today, which is aortic incompetence or aortic valve insufficiency or aortic regurgitation due to pathological growth of connective tissue after attacks of rheumatism, rheumatic endocarditis, aortic valves shortening and cannot close the aortic orifice during diastolic period. You know from physiology, at the beginning of diastole, pressure into the aorta higher than into the empty left ventricle. As a result, blood come back, but normally semilunar valves immediately close and stop come back blood flow. In our case, they cannot be completely closed and blood regurgitated. We are talking about aortic incompetence or aortic regurgitation. during diastolic period, together with blood which go through the normally opened mitral valve, blood come back from the unclosed aorta. And you'll understand, left ventricle will be overfilled with blood. We are talking about diastolic overloading with volume. To decide this problem, left ventricle dilated and hypertrophy. Dilated to take blood, hypertrophy to push it during systolic period. And then more significantly, unclosed opening, then more blood come back into the left ventricle. Then less blood go to peripheral organs. And again, we'll see same problem as in aortic stenosis. Diminished blood circulation in greater circulation. And patient again come to you with complaints which are characteristic for deficiency of the blood supply of inner organs. And first of all, heart. Patient feels heart pain like angina pectoris due to relative coronary insufficiency because heart hypertrophy to compensate ejection of blood, but due to problem with low diastolic pressure will be inadequate filling of the coronary arteries because coronary circulation depends from diastolic blood pressure which becomes insufficient. Patient feels giddy, sometimes can lose consciousness due to deranged blood supply to the brain and low diastolic pressure. And symptoms which indicate about decompensation of the left ventricular contraction and congestion of blood in left circulation, dyspnea, tachycardia, weakness. You see, first of all, problem with greater circulation, low blood supply, and then dysfunction of the hypertrophic left ventricle. On inspection, patient pale, aortic heart defect, white heart defect due to insufficient blood supply to the arterial system. Then more blood come back through the unclosed aortic orifice, then more bad condition of the patient. Aortic regurgitation is very rich with visible signs and will obligatory examine vessels of the neck to reveal specific palpation of carotid arteries, carotid sheathing. Why it appears? Because carotid artery is near the heart, and you will remember left ventricle overfilled with blood and heart stroke will be high. And at the beginning of systole, carotid artery completely filled, overfilled with blood. But then at the beginning of diastole, blood come back into the left ventricle through the unclosed aortic orifice. And carotid artery becomes empty. And we see as it's dilated during systolic period, collapse during diastolic. Dilated collapse, which is visible palpation of carotid artery, which is called carotid sheathing. Same mechanism for arrhythmic movements of the head, synchronous with palpation of carotid artery and peripheral path. Which is Muset signs, which also characteristic only for aortic regurgitation, rhythmical movements of the head, which help differentiate it from psychic disorders when the head movement is asynchronous, with obligatory synchronous with palpation of carotid artery. If we'll pay attention on capillary pulse, you can reveal positive capillary pulse because we'll see rhythmic contraction of the body between white and red color of the compressed nail. Positive capillary pulse or Quincke pulse. And if you rub skin any side of the body, sometimes you also can see it rhythmical reddish due to pulsation of capillaries, which overfilled with blood during systolic and empty during diastolic period. All these symptoms are characteristic for aortic regurgitation and connected with different volume circulated blood during systolic diastolic period, and as a result disordered blood pressure. It will be high systolic and low diastolic because high heart stroke and deficiency of circulated blood during diastolic period. On palpation, we can reveal displacement apex bit again, which will be diffuse, high, and restricted due to hypertrophied left ventricle. Peripheral pulse will be fast, full, and high at the beginning of systolic period because high systolic pressure, high pulse pressure, and increased volume of blood which ejected into the aorta during systolic period. But then it very fast decreases, which is called fast pulse because volume of pulse change. First of all full and then empty. On percussion, will be problem only with left ventricle and as a result displacement of the heart body to the left due to hypertrophy of the left ventricle. It will be more significantly affected semilunar aortic valve. On auscultation, will again start from the heart apex, but main picture will be over aorta. First sound diminish, first of all due to decreased muscular component, hypertrophied left ventricle, and it will be result of incompletely closed mitral valve. Later we'll say about relative mitral valve insufficiency because due to to take comeback blood, left ventricle first of all dilated and then compensatory hypertrophy. And if it's dilated, mitral orifice also dilated and normal mitral valve becomes not enough for dilated orifice. As a result, orifice cannot be completely closed and blood come back through the small slit. If valve not closed, no valvular component. First sound diminished due to hypertrophied left ventricle and relative mitral insufficiency. Second sound over aorta diminished due to absent its main components, no period closing semilunar valve, no valvular component. And main signs of aortic regurgitation, which is diastolic murmur over aorta, which may be auscultated over Botkin air point also, along comeback blood flow. And again, I'll remember you. Main signs of aortic regurgitation is diastolic murmur over aorta with irradiation in the Botkin air point. I want to stop to characteristic of functional murmurs which are characteristic for aortic regurgitation and will be heard over heart apex. Now, I said you about formation of relative mitral incompetence. I'll again remember you due to dilation of left ventricle and dilation of mitral orifice, Hale's mitral valve becomes insufficient for widening mitral orifice. We are talking about relative because no anatomic defect, mitral incompetence, which manifested with systolic murmur over heart apex. Diastolic Flint murmur, again over heart apex due to relative mitral stenosis. You see, aortic and mitral orifice localizes near it, and when blood comes back from the aorta due to unclosed aortic valve, it's push on one cap of mitral valve which rises. As a result, during diastolic period, when the blood must go from atrium to ventricle, mitral orifice slightly diminish. On the sides, rise one cap of the mitral valve. We are talking about relative mitral stenosis because no growth of connective tissue, no anatomic defect, relative. As a result, blood go with turbulence movements. We are talking about diastolic Flint murmur. Patient with aortic regurgitation over heart apex may be heard to both systolic and diastolic murmur. Systolic due to relative mitral incompetence, diastolic due to relative mitral stenosis. Will auscultate peripheral arteries. In aortic regurgitation, we'll hear two phenomena over femoral arteries. Double Traube sound, we'll hear vibration of femoral artery during systolic and diastolic period. And if we'll slightly press stethoscope, we can hear double Vinogradov-Durazier murmur. We'll hear normal and abnormal compared blood flow through the artificially narrowed femoral artery. Mechanism of both phenomena I explained to you when I said about auscultation of peripheral vessels. Arterial pressure in aortic regurgitation will be changed. I said you systolic pressure rises due to increased heart stroke because heart push more high volume from the overfilled left ventricle. But diastolic pressure falls because if the blood comes back, blood flow in peripheral vessels decreases. It's controlled diastolic blood pressure. As a result, pulse pressure increases. For example, systolic may be high, diastolic low. Pulse pressure, deviation between systolic and diastolic pressure increases. On ACG, will reveal signs hypertrophied left ventricle, deep S wave in surge standard lead and high R wave 5-6 chest lead resembles ACG patient with aortic stenosis. On X-ray examination, aortic shoes-like configuration of the heart due to significant hypertrophy of the left atrium. And we see wave of the heart. Sometimes may be revealed dilation ascending part of aorta due to ejection of increased blood volume at the beginning of systolic period. You see Specific shows like configuration of the heart due to hypertrophy of the left ventricle. Echocardiography show problems with aortic valve. During diastolic period, blood go only from left atrium into the left ventricle. But you see, aortic valve also open, which must be closed. Two blood flow, normal and abnormal. Doppler echocardiography will show regurgitated abnormal peak of the blood. Blood go to normal direction from left atrium and abnormal from aorta. Again, you can see normal blood flow, which is blue, and abnormal blood flow, red, from the aorta into the left ventricle. That's all information which I want to give you. Today was last lecture. We'll meet with you next term. Be healthy, be happy, happy new year, and successful mark on exam. Goodbye, thank you so much for your attention.